Good morning and welcome to the Paramedic Services Committee meeting for February 6, 2024. I'd like to acknowledge everyone in attendance and welcome Councillor Hunt from the City of Brantford, new member to the committee. I'd like to open the floor to nominations for position of election of chair. Councillor Pierce.
Councillor Miller.
Councillor Miller, do you accept?
No, I don't.
Okay. Is there any more nominations? Councillor Miller.
I will nominate Councillor Martin.
Councillor Martin, do you accept?
I will.
Thank you. Is there any more nominations? Can I have mover to close the nominations? Councillor Pierce. Mayor Davis. And can I have nominations for the position of vice chair? Councillor Pierce.
Councillor Miller.
Councillor Miller, do you accept?
Yes, I will accept.
Okay. Is there any more nominations? No. Can I have a mover to close nominations? Mayor Bailey and Councillor Pierce. Thank you.
Okay. Can I get some move approval of the agenda? Yeah, thank you. All in favor? Carried unanimously. Any declarations of pecuniary interest? Seeing none, we have no delegations or presentations. Adoption of the minutes. Moved by Councillor Pierce. Second by Councillor Miller. All in favor? Carried unanimously. Staff report. Statistic package. Director King.
Sorry, through you, Mr. Chair, I will answer any questions regarding the statistical report at this time.
Russ.
Through you, Mr. Chair, I will answer any questions you have regarding the statistical report at this time. If there's no questions, I will provide a brief update.
Councillor Miller.
Thank you, Mr. Chair. Through you to Russ. 2023. I'm comparing 2022 to 2023. In 2023, we added basically one additional ambulance, correct? 7.5 to 8.5. 2023, we've seen 3.9% less calls. Time on task and offload times are 10 minutes lower, or 10 minutes quicker in 2023 again versus 2022. So everything looks better in 2023 versus 2022, except for the number of code zeros, which went from 830 in 2022 to 908 in 2023. And I wouldn't expect that based on the fact that we added an ambulance, we had less calls, and there was less time on task. So I just wondered if you could kind of explain to us why the number of code zeros went up.
Through you, Mr. Chair, the new data set that we now collect gives us more accurate data. The data in early 2022 into 2023 up until October this year was a manual calculation of the amount of code zeros we have. The new data set gives us accurate numbers. Also, a code zero depends on multiple different factors. It could be call volume at the time. So we have, for an example, 10 vehicles and we get 16 calls in a 4-hour period of time at offload delays. That would significantly add to the number of code zeros that we have. So it's multiple factors. We have made improvements with the 8.5 staffing hours that we currently have. We had a capacity last year of over 100%. Our capacity is now to 94%. We have made improvements, but code zeros, as I said, has multiple factors. Surge volume, hospital delays, but we now have a more accurate way to track this.
Okay, so slightly different way of tracking that data. Okay. Second question through Mr. Chair to Russ and maybe to Cindy, I don't know. Call volume capacity is at 94.7% in 2023. At what level? Where do you get to in terms of volume capacity when we as a committee have to start asking ourselves that hard question of when is it time to add another one. And I hate asking that because they're not cheap, but when do we start asking ourselves that?
Through you, Mr. Chair, if you look at the tracking of our ongoing capacity, when we first started doing the tracking about 2014, 2015, we were about 94, 96%. That's where we've always been, except for the years leading up in 17, 18, 19, we were over 100% capacity. This committee back in 2014, 15 adopted a third-party agency to review our overall call volume and our strategies. And then it continued to go up with the support of this committee. We have added ambulances, and their recommendation in 14 and 15 was to add a minimum of a 12-hour vehicle every second year to go with growth. But there are other strategies out there that we can also look at moving forward.
Okay, just to follow up then, Mr. Do you see that in the short-term horizon, that request coming before this committee within the next year or two?
Through you, Mr. Chair, I have not done the analysis for 2023 into 2024 yet. I will have a more clear picture at our next meeting. I believe it's scheduled for April or May, and I'll be able to advise the committee at that point in time. But we are looking also at other strategies to help mitigate that.
Yeah, no, I understand the other strategies, and it would be good if they were paying off. So, okay, thank you.
Mayor Davis.
Thank you, Mr. Chair. Got a number of questions about the offload time situation. And my first question through you to Chief Kings is, it looks like the offload delay time in 2023, there was a slight improvement over 2022, about an average of 10 minutes.
Through you, Mr. Chair, that is correct.
Okay. And if you're to break that down into quarters for 2023, every 3-month period, did that improvement take place in the first part of the year, the second part of the year? Did it happen kind of ad hoc through the year? But
through you, Mr. Chair, it happened, the improvements happened within the first 2 quarters of 2023. At the third and fourth quarter of 2023 is when things started to getting to the point of unmanageable, back to where the old rates used to be. So if we continued on all of 2023, quarter 1 and quarter 2, you'd see greater improvements on that time now. But with, as I said earlier on in our new tracking in our data set that we have accuracy to, we were tracking lost time per day. I've got the stats right here. Lost time per day in the emergency department due to offload delays. We started doing more of an, before September, we were saying we were losing 22 or 23, and that was all manual. When we used this new data set, we lost 920 staffing hours in October, 1,500 staffing hours in November, and 2,400 staffing hours in December. So to equate that into accurate, better visualization, we are staffed 204 hours, vehicle hours a day. So in an entire month, we're 6,300. For the December, we lost 2,400 of those hours in offload delays staying at the hospital. If you equate it that way, last year, and again, this new tracking has really opened up our eyes because we get a visualization every 24 hours. So at 9 o'clock every morning, our admin assistant takes ground zero all the way to 9 o'clock the next day. And it fluctuates from, we've lost 5 hours, 10 hours, or whatever, and fluctuates. And our worst day on record was, I believe it was 101 hours, 50% of our staffing in offload delays at the hospital. So we've now got this data in front of us that we now are looking at a different strategy to deal with.
Well, that's alarming.
It is very alarming, sir.
And is there a factor in that? Why? Why is it deteriorated so significantly?
Through you, Mr. Chair, maybe it was bad before, but not as bad as October, November, December. We have never seen these figures before. We've met with the hospital as soon as last week with the new committee to try to address our offload delays. We've asked for better communications with their staff to make us a priority that when we do walk in those doors, and I do not mean this disrespectfully, that the people that are in the waiting room that have walked in and stuff like this, that our vehicles get put back on the road immediately to the best of our ability. We provided the hospital with over $750,000 of applied grants that we've actually applied to the hospital for offload and back hallway nurses. The program fully launched, and that was in my previous report, November 15th of 2023, to improve that. But with the surge in RSV and other ailments, the emergency department was completely backed up. And we're just part of, to the point on a few occasions that they needed our monitors. That was how critical the patients were in that department. So we were more of an extension working with our community members of the hospital.
Okay. So you mentioned this funding. So this funding, I think it's referred to in your report, is that the one-time funding of $628,234 to support the dedicated offload nurse program? Is that what you're talking about?
Through you, Mr. Chair, to clarify, we've always received $146,000 annually since 2014, which we refer to that as the offload nurse. The offload nurse commits up to 6 beds for us for surge capacity. Last year, in December of 2022, we applied for limited funding to take us to March 31st of 2023. That we received an additional $150,000 to help, which we call now the backhaul nurse, which is an additional 6 beds. In that same 3-month time period, we applied for the $628,000 so we could run the backhaul program 365 days a year. The hospital, due to staffing and other things, did not really get that program fully launched till about November, and right now it's staffed about 75% of the time.
Okay, so if I understand, so the province is giving us about $700,000 a year in kind of dedicated funding.
Correct.
And the idea behind that funding is that's to purchase for the paramedics some of the, I guess, resources in the emergency department so offloads can happen quicker.
Correct, and there's enough funding in there to provide for the backhaul nurse is 24/7 nursing support, and the offload nurse, it's 7 days a week on average from 7 till 7 every day.
Okay. So how many additional nurses is this money intended to pay for? Is it just one or is it 2?
You would have enough funding there for the 24/7, and I'm just doing it in my head right now, for 4 full-time nurses for the backhaul, because it's 24/7 coverage, just like an ambulance. It would basically be the same. And then the funding would be for, I would say, 2 full-time nurses with the funding, 1.5 full-time nurses for the offload nurse, just because of their hours.
So is the idea then that these nurses, that they'd be dedicated to taking patients from the paramedics so the paramedics can then leave and get back on the road?
That is correct, sir.
Okay. And how does that work? Do we get the money? Does the province send the money to the county? Does it send it to the hospital? Like, how does that money flow?
To control the flow of the funds, it was a paramedic service through previous committees applying to the federal provincial government for that funding. We are billed monthly for those services that they provide to us, and the county pays the bill to the hospital.
So you say you mean the hospital bills us?
Bills us correctly. We get an annual or basically a monthly invoice for the services that they provided.
And does that bill go up and down depending on how many nurses are actually available to take patients from the paramedics?
The dedicated offload nurse is static because that's staffed, I'd say 99% of the time. The offload, the backhaul nurse, I'm sorry, it gets confusing trying to keep track, but the backhaul nurse, it does fluctuate.
Okay.
Through you, Mr. Chair, we even, because of the amount of funding we had, we even decided and worked with the hospital to be creative. Besides the 24/7 nurse, we said, there's enough funding here because your program didn't start till a little bit later. You can have a noon to midnight nurse, and that can help you with any escorts and transfers and everything else. So we're trying to do our best, including the amount of upstaffing that we do to cover. Because through the Christmas rush, we're trying to come up with ideas. And 2 years ago, we brokered an agreement with Norfolk General Hospital for diversion. It was the paramedic service that did that. And we brokered a deal that when we have a large sum of lower acuity patients, our worst is a CTAS 1, our lowest is 4s and 5s. When our hospital is backed up, we would contact Norfolk General Hospital and say, will you take some of our patients? Because by the time our crews leave Brantford, go to Norfolk and come back, we'll say hour and a half round trip. Those same vehicles with a lower acuity could be at Brantford General Hospital for 3, 5, 7 hours, just depending on their space and capacity.
So how much on average do we pay the hospital for this dedicated service?
Right now, I just did an analysis last week prior to the meeting. For the funds that you said, it was just over $700,000. There's still $220,000 remaining to cover us until the end of March. And my calculations, it will not be fully spent.
Okay. So are we getting the service that we're paying for?
Through you, Mr. Chair, everybody's struggling with staffing right now. There are ways of improvement, and we discussed ways of improvement at our meeting 8 to 10 days ago. But talking to other services, Hamilton has improved their offload issues greatly. And I was actually talking to Chief Sanderson the other week. The hospital has to realize, and we do understand we need a new hospital. We do understand that there's not much real estate there, but we need to be the priority out there. That we did have a couple instances that were of CTAS 1 nature, that people waited to have vehicles coming from Six Nations, Waterloo, Oxford, Hamilton into our community because of that. So we're trying to improve the internal process with the hospital and have things in place that we are the priority coming in and out, especially when we have nothing on the road. Our superintendents, our deputy chiefs, have a dashboard that they can see by minute, and it's a speedometer. If we're tracked for 10 vehicles, it shows 10 vehicles, and now that speedometer goes down to 0. We're basically in a code 0 situation. Our supervisors get out there and they start responding to calls in their ERVs. So we're trying to mitigate some solutions internally, but we need the hospital to work with us in partnership to get these solutions moving forward.
Are they working with you?
They are starting to work with us now. We're hopeful. We've had meetings in the past that COVID and everything else may have stalled things. We are hopeful that it is. And again, only time will tell. I can't foresee. There's a brand new CAO in place, and we have to give that person the opportunity to try.
Yeah, fair enough. It's been, I think, 10 months since Mr. McNeil left, the former administrator. So is there anything that we can do as a oversight committee to assist you or assist the hospital? That I realize there's not much we can do as a board, so to speak, but is there anything we can do to help?
Through you, Mr. Chair, your support, I would prefer to not discuss it in this forum if that's a possibility. We have opportunities of other times, but in this forum, I would not want to discuss the solutions I have currently in place.
All right. Well, I just want to say thank you, Chair, for letting me go on for a little bit. But, I want to thank the service for everything you do under the most trying of circumstances. And, I understand the situation in the hospital is trying for them as well. Hopefully we can, working together, find some way to make the whole system work better. And just lastly, if there's anything we can do that we at the city can do to help, be happy to be told what that might be and do it.
Through you, Mr. Chair, I just want to add one more thing. If we ever went the route, and I've thought this through, of withholding funding, it's still, I don't think that would be the ideal way of going, because if we do that, they just don't provide us the beds. They also take away the beds now that if they're short-staffed. So if they're short-staffed, 2 nurses today, we don't get the backhaul, we don't get the dedicated, and it's to fill their department, right? And we're just the add-on to it. So we need to have more creative ways of finding a solution and working together.
Yeah, I'd agree with you that withholding the payments would be seems to me like a drastic loss.
Correct.
And we'd want to try everything but that.
Correct, sir.
Thank you.
Councilor Pierce.
Thank you, Mr. Chair, through you. And Russ, I'm just going to pick on something that not pick on it, but just something you said at the end there that, if they're short, then we don't get the offload beds, we don't get the backhaul beds. Maybe I'm misunderstanding this. It's my understanding that this funding allows us to pay for an offload nurse. So and this is going to sound bad, I don't mean it to sound bad, but if the ER is short a couple nurses, that shouldn't affect our offload nurse, or do they just go, we need you here? To me, if that's the case, then we're paying for a dedicated nurse, to the mayor's point, that we're not getting. So am I understanding that correctly, that that's how it would work?
Through you, Mr. Chair, that is 100% how it works. When we had the short funding from, say, January 1 to March 31st last year, and we had a pot of money, we did everything possible. We even asked them to bring in agency nurses so that we could fund it and get ourselves in a better position. Right now, the ministry is not funding agency costing for nurses, right? They're funding for static nurses, right. But we'll say it's like a fire truck. The minimum complement has to be, say, 5 firefighters on that truck. If they go below, they have to bring in overtime, whatever the case is. I believe, and I cannot confirm, that's the way the emergency department needs to function as well.
I think that's a fair statement. So that being said, if this money's coming from the province, and I'm not sure what they can do, but is there any possible way we can leverage the province to say, hey, look you're giving us this money for XYZ. We're paying for XYZ, and that's being taken away from us by the hospital. I'm not sure, and I know you guys are doing everything you can to try and make this work, but I'm just wondering, is there any way to leverage that the province, in the sense to have I'll call it that stern discussion with the hospital to suggest that, hey, you know what, if you're short, you bring in your own staff for the extra bodies. You don't touch this one here. I don't know if that'll work or not, Russ, but that's a tough one, because in essence, we're paying for hospital staff at times, which is not what this money was for.
Through you, Mr. Chair, I look at it that if they have a budget, they're not going to bring in overtime to staff their area when they've already paid regular time for our backhaul nurses, right? And to staff their department and keep within budget. They're not making any additional funds from staffing us. If we had with the province the ability to approve agency nurses, or if we had the ability with the province to say that at all means cover our backhaul nurse and cover our dedicated offload nurse at even to the point of an overtime rate, that would be beneficial. But then a lot of hospitals would, from talking to other counterparts, right, go to the overtime route first, because the staff would only take those backhauls if it was overtime. Right. So it's kind of one defeating the other.
Yeah, I don't envy your position in that one. Okay, yeah. So like I say, that's kind of a tough pill to swallow, but I know you're working on trying to get that through, so that's great. And it is, when you fire those numbers out of the new stats, that is more than alarming, the amount of lost time on that. So, and in the conversations with the hospital, are they seeing that? They're aware of that, to say, hey, look, we've lost, in essence, 40% of our time sitting here waiting. But anyway, as far as the stats, again, I'm a numbers guy, and I love the numbers and stuff like that. And I don't know if I'm getting too picky here, but some of the stats go 2014 to 2023. Some of them go 2019 to 23. Some of them go 2015 to 23. And even within the separate things, like the code zeros, there's one. There's an annual code zero that goes from 2014 to 2023, and then there's a monthly code zero that goes from 2019 to 2023. So I'm just curious, either can we, you know, I don't want to say get rid of, but can we
Align.
either align them, and even if we started, you know, the last 5-6 years, so they're all consistent. Like it's interesting to look back at 2014, but in essence, that's 10 years ago, and that's not really helping us right now. Like it's interesting. Like I say, it's interesting to see the numbers, but I'm trying to just balance everything out historically to see where the ebbs and flows are, and I'm just wondering how difficult it would be to kind of align those years, say the last 5 years or the last 4 or 5 years or something like that, consistently through all the stats. I don't know if I'm getting too picky, and I don't want to put a bunch more work on your plate, but if that's possible, that would be great.
Through you, Mr. Chair, that's not a problem. We're just trying to, from the inception of tracking the stats, right? Some were available to us, some are not. Right. So we're just taking the stats that we've had before. So yeah, I don't have a problem with aligning it that says 2015 and then next year it'll be 16 and 17 as our starting point, right? We can align them. That's not much of an issue.
Okay, yeah, it's great. Like I say, I don't want to be too picky, but I'm just trying to balance things out.
Okay.
Yeah.
Thank you, Mr. Chair. I just wanted to add one comment to some of the challenges that we're having with the hospital. And Russ eloquently outlined a number of things that we've been working on. I wanted to advise the committee that I have met with their current CEO to discuss the matter, noting I know that she will be vacating the position, but she certainly did recognize in our conversation that this is a significant challenge for us. And there was a commitment to develop a strategy and action plan between the BGH staff as well as our paramedic service jointly. And we did have a meeting with a number of their staff last week. They did bring to the table a number of ideas that they felt that we could explore and work on together. So it was a productive meeting, I thought, that we had with them. They do have a new position there as well, someone who's fairly new and working on quality improvement initiatives. And one of his key priorities for 2024 is to mitigate the offload delay situation. So we'll have a team of staff that are working with them regularly to develop the action plan strategies. And we'll come back to committee with that information, but I expect it will take several weeks to work through that.
Okay. Are we done, Councillor Pierce?
I am, Mr. Chair, thank you.
Okay. Mayor Bailey.
Through you, Mr. Chair, to Russ, how often do we get there and the nurses that we expect to be there aren't there because they're too busy? And how often does that happen to us?
Through you, Mr. Chair, it's random. We have our superintendents go up there and advise us what we have for the day so we can basically staff accordingly. As I said, when they're backed up for the entire day, we end up either upstaffing or upstaffing an ERV to basically respond to calls with our community. But it is random. Some days we don't, some days we do. We, right now at 5 o'clock, the problem is that it's starting at decanting at about 5 or 6 o'clock at night. If they don't have a nighttime backhaul nurse, they start taking those patients in the backhaul and putting them into beds, and then we lose that extra real estate at that point in time. So we're hoping, as again, they had the commitment of November 15th to fully fund it, but they are bound by people calling in sick and what their needs of their department.
So if we, even if we don't have 4 in the back, would we still have maybe 1 or 2 if it was a busy night, or would we have nothing?
We would have only the dedicated offload nurse. The original funding finishes at 7 p.m. nightly. If we don't have a backhaul nurse, we have nothing.
Thank you.
Yeah. Before I go to second time speakers, I got a couple questions. If an ambulance is dispatched to a CTAS 5 and they haven't arrived yet and the call comes in for a CTAS 1, are they redirected?
They are redirected. The only time that they cannot be redirected is on a code 4.
Code 4, okay. And you talked about driving to Norfolk with the non-urgent cases.
Mm-hmm.
Is there any way that instead of doing that, we can just transfer them to the waiting room so that they can wait? Because if they're non-urgent, they don't really need a paramedic standing over them.
Through you, Mr. Chair, there is a Fit to Sit program at the Brantford General Hospital that has certain criteria, and it's the assessment of our crews that that person would meet the Fit to Sit. But again, working through the communications and stuff, not all the times of our assessment equals what the nurse's assessment are at that point in time. Or the patients in lower acuity, like 4s and 5s, may need a bed and cannot sit into the waiting room. That's the choice of the paramedics to take them out to Norfolk to place them in a bed, because the elderly lady or whoever we picked up may require a bed rather than just a chair in the waiting room.
Okay, so the ones that you can, you transfer to the waiting room.
Correct.
Okay, and interfacility transfers, I thought we stopped doing that.
Through you, Mr. Chair, the Ministry of Health, we can do inter-facility transfers if the hospital calls our dispatch cannot refuse.
Okay. Councillor Miller.
Thank you, Mr. Chair. Just a question of clarification, because Russ talked about lost staffing hours. What is an hour? Is that one paramedic for an hour? Or is that a full on ambulance with 2 paramedics in it? What's a staffing hour?
So a staffing hour is 1 ambulance with 2 people.
Do you know how much it is per hour, the cost?
If I was to, just taking their wages and everything else, per hour, we would lose, including vehicle hours, $150 an hour.
Okay. So if you said, because you said the highest one was 100 hours per day, we'd add a couple more zeros. I mean, that's $15,000
Correct.
in one day lost because of waiting time at the hospital. I just want to put it in a context that we could understand. So we're losing, okay, so if we've lost 2,400 hours in December, times that by $150, that adds up. Okay, thank you.
Thank you, Mr. Chair. So I'm sitting here trying to think of what we can do, if only temporarily, to help. This may be something that one should never say, but I'm wondering in terms of our fire service, and we have elements in our fire service, obviously not nearly trained like paramedics, but they have some basic, like first aid wouldn't be the right word, but some ability to assist with some calls. Has that ever been thought about, considered, like using elements of our fire service that would have the ability to respond to certain types of calls?
Through you, Mr. Chair, we do have a tiering agreement both in the county and city that meet the criteria of the calls that they would go to and assist us with. That tiering agreement has been in place for multiple years. Every couple of years, we do review it to see if there's anything else that they could assist us with or make changes to.
Do you think that's something we should look at?
Through you, Mr. Chair.
Utilization of the fire service to help paramedics.
Through you, Mr. Chair, I think our current agreement is very solid with their abilities, and that's why the chief of the city and the chief of the county, we review these tiering criteria. Everybody wants to help, but we don't want to overextend their abilities at that point in time just to put a stopgap in there, and that's why we do have those agreements in place.
Yeah, and the reason I brought that up, Chief, is because hopefully the situation in the hospital will improve over time. Just wondering how, if we're facing kind of a hump, how we get over that hump. But you know better than me. I was just kind of brainstorming, thinking.
Through you, Mr. Chair, what we're also doing is our superintendents are going up there on a regular basis to coordinate and communicate with the charge nurses. And when we do need help, they are trying. They are honest and truly trying, but if it's their surge capacity upstairs and no beds move and they're at capacity, they're even having hallway beds on the upper floors. They are backed up in the emergency department. Our lack of urgent care locations within the community. I think that when Cindy and ourselves met, they saw the urgency in our voices, in our statistics. We saw this coming back in 2018-19 with the surge that is coming, and we suggested the diversion. We got the diversion the first time. They're now working with us to get other diversions into place in Oxford and Waterloo and all that to help us. The hospital's small, it's at capacity, but I think now we have a fresh foot to try to work together to come up with these solutions. Because if you saw that I lost 22 hours last month, that's all you saw, it's not a problem, right? 22 hours is nothing. But now that we can show them true stats of losing 2,400 hours, we had 150 code zeros, not just 8 or 28 last week, right? Seeing that urgency and the statistics there, I have to say that they now understand what we've been trying to say for the last couple of years, but more in a supportive, real number scenario.
Further to your comment about firefighters, one thing firefighters cannot do is transport patients. That's probably where we need the most assistance. Councillor Pierce.
Thanks, Mr. Chair. Just to add on to that conversation and kind of circle back to what I was saying about the province, I appreciate the fact that, you know, they seem legitimately concerned and they understand the numbers. Again, my whole point in this thing is this is money that's coming from the province to pay for certain staff and beds and all that kind of stuff. And I don't know whether it would help or hinder or just what. I don't know how it would be perceived. But I'm wondering if it may be somewhat beneficial to have our MPP involved in one of those conversations, just to kind of be there and listen, to understand, to hear it firsthand from the hospital side and from your side, and seeing the stats, and may or may not have an opinion on that, and may or may not take that back to the product. I don't know. Like I said, I don't want it to come across as we're pulling the heavy, we're bringing in the province, but at the same sense, maybe that might add on to their urgency to fix or change things. I'm not sure. I just throwing around an idea again, just to kind of. I guess the point I'm trying to make here is if I'm the province and I'm giving these, because I'm sure we're not the only municipality or service that's getting this funding from the hospital.
You are correct.
For this services at the hospital. And I'm sure, as we've said before, we're not the only ones in the issues with the offloads. So if all of a sudden this becomes a bigger thing and it's found that there's, you know, multiple hospitals around the province that are, I don't want to say doing the same thing, but having the same result of this funding that's coming from them, maybe they can persuade. I'm not sure.
Through you, Mr. Chair, I like the idea that you had dealing with the MPP, but I'd just like to add a little bit more context of coming up with solutions. Currently, we have one of the best CP programs in Ontario. We have CPs that could show up at scenes. Say we go to your house and it's not an ailment that's required to take you to hospital. In other jurisdictions, the CP is dispatched to your house and basically stays with you until a family member can come by or whatever the case is, avoiding the transport of an actual vehicle. Currently, we're not in that position because of the dispatch system, but currently it's not allowed through our dispatch in the province of Ontario. So our Deputy Chief Glenn Kinane CP program and CPs could technically, as other services do with the new dispatch system, get dispatched to these houses, avoiding transport rather than, but these are one of the solutions. But because of, and Deputy Chief Kinane just wrote a letter to MPP BOMA asking for, can you look into this, because it makes sense of utilizing all your resources that we currently have within the city and the county to mitigate our transports. But our dispatch center is not funded nor equipped to dispatch CPs in our community to go to a 911 call for a loved one of yourself to allow that transport vehicle to go somewhere else.
Right.
So if that brick wall could be removed or mitigated through, we'd have our resources of our CP team that could help us delay transports and offloads as well.
Okay, again, I appreciate, I know you're doing everything you can. I'm just trying to find some leverage is all.
We appreciate it. Thank you.
Councillor Hunt.
Thank you, and through you to staff. I'm wondering. I'm thinking outside the box. I know that the the nurse, so the offload nurse and the backhaul nurse are currently employees of the Brantford General Hospital, and as such, the Brantford General Hospital can allocate their resources, which they're chronically understaffed anyway. But has there been any thought to the offload nurse and the backhaul nurses actually being employed by the paramedic service, or is that something that is not the hospital would not be open to having basically non-hospital staff working within the hospital? I just think that would give us further control over that particular. I mean, you've mentioned agency nurses not being allowed in, but if those nurses were actually employees of the paramedic service.
Through you, Mr. Chair, the agency nurses are allowed in, but they are basically double the amount of hourly costs that we are currently funded to. So our funding model does not allow to pay for the agency nurse of coming into the area. We'd love to have them. They'd probably be lined up to do that job at the backhaul and the dedicated offload nurse, but it's a staffing issue. There are so many struggles of other agencies trying to staff nurses and get nurses. The ability for us to hire 4 nurses and manage that at the same time, I do not believe that would be beneficial to everybody regarding extra benefits and additional costs associated with that. But it's something we can look at that point in time.
Yeah, just an idea. And I will tell you, I'm a frequent flyer, both the paramedic service and very familiar with the off-haul or the offload. The backhaul, I will tell you, the staff that are there are doing the best they can with the resources that they've got. But our healthcare system is just chronically understaffed, and you know we're unfortunately left dealing with those issues that we're discussing today on a regular basis.
Through you, Mr. Chair, thank you, Councillor. My other concern is, besides the hospital staff and our staff, it's the overall mental health of what's going on there. They hear, like, the staff basically have so many patients come in and they can't manage everybody. Our paramedics hear of calls happening, but they're stuck in the emergency department, right? It really takes a toll on both our department and also the hospital department and the ER nurses. Everybody's doing their best and coming up with a solution, but we're seeing some roadblocks that we'd like to work through.
Okay. Mayor Davis.
So Chief Kings, we know part of the problem is the staffing issue. And I think part of the issue is just the building itself.
Through you, Mr. Chair, correct. And we are also now in construction season.
Right. Mr. Chair, we know that hospitals are a provincial responsibility and the province is entirely responsible for the development and improvement of hospitals. But wondering if you as chair and Councillor Miller as vice chair might consider going to Queen's Park and making the case for accelerated development of the new Brantford General Hospital.
Something to consider, yeah.
Being chair and vice chair carries with it certain responsibilities. Road trip.
Okay, seeing no further questions, we'll call the vote to receive the report. All in favor? Carried unanimously. Do we have any communications? Any other business? With that, we need a motion to go in camera. Moved by oh, okay. donation of an ambulance.
Yes. Yes. We were unsure on how long this meeting would actually be going.
Is all the media that we need there, or are we waiting on somebody that might come later?
We said 10 o'clock, so I don't know.
Jump into the in-camera then. Moved by Mayor Bailey, seconded by Councilor Miller. Questions, comments? We're going in camera for labor relations and employee negotiations. All in favor? Carried unanimously. Okay, we're back in open session. Next meeting is May 7th at 9 o'clock. If there's no other business, we are adjourned. Thank you, everyone.